In an average chronic disease patient panel, up to 50% of people have stopped taking their prescribed medications. This lapse in treatment is linked to approximately 125,000 deaths annually in the United States and drives 25% of all hospitalizations. Patients rarely call to tell you they missed a refill. The prescriptions lapse quietly, and the practice usually remains completely unaware until a severe complication shows up on a chart. What looks like a sudden clinical deterioration is often just a predictable, invisible, operational failure. For practices managing Medicare Advantage populations, that operational failure carries a direct financial penalty. In the CMS Part D star ratings, adherence measures for diabetes, hypertension, and cholesterol carry a strict triple weight multiplier. Due to this heavy weighting, the percentage of Medicare Advantage plans hitting the 4-star threshold has plunged from 68% down to just 40%. Missing these adherence targets ultimately strips away the quality bonus payments that practices rely on for revenue growth. Most clinics try to solve this by handing medication outreach to the front desk, asking an already overwhelmed coordinator to fit it in between patient check-ins. You can see the friction in this process. A coordinator pulls a payer list, cross-references fill data, attempts to triage by clinical risk, leaves a voicemail, and manually documents the effort. The system jams because there are simply too many moving parts for a shared role. Worse, clinics rely heavily on phone calls. Statistically, dialing numbers and leaving unreturned voicemails is the least effective method for engaging a non-adherent population. Adherence outreach is a high-volume logistics problem. Treating it as a secondary, part-time task guarantees a backlog. High-performing practices extract this workflow and assign it to a dedicated remote specialist operating directly inside their existing EHR. This flow sequence shows the optimized approach. An AI engine intakes the raw list of non-adherent patients and automatically filters them into prioritized risk tiers before a human specialist even logs in. From there, the specialist deploys a multi-channel strategy. As the highest priority tier branches out into calls, portal messages, and texts, notice that the text pathway dominates. Automated text messaging alone has been shown to double the odds of patient adherence. The remote team executes all the administrative legwork. They track down the refills, map out the logistics, and only escalate true anomalies, like adverse side effects or patient confusion, back to the in-house providers. Every contact attempt is logged in real time, instantly securing the documentation needed for value-based reporting. Assigning a dedicated owner to this precise logistics pipeline ensures the outreach happens, and it lets the in-house team go back to actually practicing medicine. This side-by-side comparison breaks down the financials. An in-house coordinator carries a fully loaded annual cost of $60,800. A Staffingly remote specialist costs $21,600. As the in-house bar recedes, the remaining space reveals what the practice keeps: $39,200 in net annual savings, a 64% reduction. This reduction in cost is achieved alongside a 99% operational accuracy rate on the very outreach metrics tied to your quality bonuses. Proper adherence management functions as an operational arbitrage. You lower your baseline overhead while capturing the value-based revenue that was quietly slipping away. Integrating this pipeline is fast. Practices typically go live within 48 to 72 hours. The transition requires 0 new platforms, 0 external logins, and 0 disruption to existing staff. To prove the ROI objectively, practices can start with a 2-week risk-free pilot program before making any long-term commitment. Closing the medication adherence drain requires a system, not a sacrifice. Restructure the workflow, and the clinical and financial results follow.